So we're going to start with a case. You are a senior resident at this point, but this is for everybody in the room. You're a senior resident. You're at the Denver Health NICU by yourself. Well, it's you and your buddy, senior resident, on at night. That matters, that it's at night by yourself. And this is the call you get. The hospitalist cross cover calls you and says, there's a lady who got admitted for some subacute altered mental status. He says, just kind of been awaited placement for the past week or so. All of a sudden just got way worse. We noticed that she's now on 10 liters of oxygen, and she's got a lactate of 4.5, and we're a little worried about her. And that's what they tell you, because that's all they know, because they're just cross-covering the patient. So I'm going to start by asking you guys, you're the senior resident, you're the resident, you're the intern, same thing. Seeing this patient, what's the first thing you guys are going to do? Take 30 seconds with the person next to you. Think through what you would do first, the very first next step you would do while you're talking to this hospitalist. And then we'll come back together as a group to talk about it.
Like a great starting point.
I'm going to call that 30 seconds. I have an esteemed group of third-year residents in the back with me, so I'm going to ask them, what's the first thing that you guys would do with this patient? What's the next step you're going to take?
So I would go see to actually go evaluate the patient. I usually like to do a little bit of pre-charting and figure out what else is going on with the patient, why they're here, what their hospital course has been. And then I start with vitals and make sure I actually see them.
So I think EA brings up a really valuable point. This is going to start with vitals. I agree, right? When they told you she's on 10 liters non-rebreather, they also told you her blood pressure is where it's been. She's tachycardic. Her vitals aren't great. But Guy then said the next step he's going to actually do is look in the chart. He's at the computer. He's a 5-minute walk away from the patient. He knows the patient's sick. He knows that there's someone there that can take care of the patient, but he would like to know a little bit more about this patient. And I agree with that. I think it's worthwhile to recognize that most things in medicine are not emergent. You do not need to be at the bedside that second, but they are urgent, and you having background information is useful. So we follow Guillet's advice, and we do some chart review. And the hospitalist tells you, yeah, they weren't really sure why she was a little more hypoxic this morning. They ordered this CTPE for her, but it wasn't back yet, or at least I said the read wasn't back yet. And I didn't really look at the imaging because I'm not very good at looking at it. But the read's not back, so I didn't look. And so you look, you're like, well, that seems like a worthwhile thing for me to look at for someone who's on 10 liters of oxygen, because I know the scenario, I know their vitals, and now I know to look in their chart. I tried to go slower for you guys today with the scrolling. I'll give you guys that one more time. No one needs to see her liver. Does anybody notice anything abnormal in this CT scan? Notice I didn't give you the lung window, so there's nothing wrong with her lungs. Tell me more. When you say filling defect, what do you mean?
You like all of the contrast.
So what does that make you worried about? Yeah, I agree. So this is why you look at all of your own images, right? Regardless of whether or not there's a read, there's only one way to become better at it, and that's to look at more images. So we'll do that together. So this is a CT of the chest with contrast. I know it's contrast because right here is contrast in the vessel. The vessels are bright white, contrast CT. Not as good to look at lung fields, but you can still look at the lung fields. But what I'm really looking at are blood vessels. So when I look at this image and I think about PE, I think I'm tracking these blood vessels. That's how I think about it in my mind. And so if I do that, I start at the top, way up here where the contrast goes in, and I really only care about two vessels, the pulmonary arteries. And so I come down typically to the bifurcation and I start here. And so that's your outflow track. And then you have a left pulmonary artery on the right side of the screen and the right pulmonary artery cutting across the mediastinum to the left side of the screen. And what you guys will notice is this is not subtle. It was not intended to be subtle. But that is a filling defect. So like Dr. McLeod was just talking about, a filling defect is this concept. But there's no contrast there, meaning there's no blood flow to that area technically. Why is there no blood flow to that area? Well, it's because whatever that is can't get contrast into it. In this case, that's a clot. Does anybody know what the term for this type of clot is? Yeah, this is called a saddle embolism, simply made because of its location. It crosses the bifurcation of the two pulmonary arteries. Other than that, it really doesn't mean anything. Just so everybody's on the same page. We'll talk more about that, but really it defines the location of the clot. It usually means they have a pretty good amount of clot burden, because if it's big enough to do that, it's pretty good size. Dr. Hudler, will you have anything to add to that?
Thank you. I feel like another thing that's important is looking to see if you can actually trace vessels out, because sometimes you'll have just a cut of a CT scan that looks like a filling defect, but it's really just you're capturing the side of the vessel wall. So really going in and making sure you can trace the vessels out. If you can't, it makes you even more concerned about there being a clot that's obstructing your blood flow from that point forward.
I think that's a perfect point. So I didn't finish my thought when I said I traced the vessels out. So I start at the trunk and then I say left and right. And I typically follow one at a time. I look at the right side first and I look at the left side first. And so like Andy was just saying, if you trace that their left PA, notice that it kind of stops, right? This is part of their pulmonary artery here, this stuff here and this stuff here. But in reality, it should be a nice linear tubular structure. You can see that there's more clot built up right there.
And you don't have anything really past that.
And you don't have anything past that, right? So you have more clot here, and then you should have a continued pulmonary artery and branches. Obviously, it wouldn't all necessarily be in one slice, but it should keep going. And you don't have anything past that. And so that's how you're pretty confident this is a pretty significant filling defect. So we have now diagnosed this patient with a saddle pulmonary embolism. Guy said, I'm going to look at her chart review. I reviewed her chart and I found the saddle pulmonary embolism. Now I'm going to go see the patient. I know what I'm getting myself into. I know what I'm most worried about right now. But before you do that, you get more chart review. The rest of it. The hospital's already got an ABG because they were on 10 liters oxygen. They were worried about them. That's their morning BMP and their morning CBC. No one had gotten new labs yet. We already knew about the lactate, and they already started working her up for infection because they weren't sure why she was so much worse and so much more altered. I'm going to move past these labs. I'm going to tell you that really the only piece that I think is significant here is that she's very clearly hypoxic. Her PaO2 is 55, which is abnormal, and that's on 10 liters of oxygen. You're going to go see her. That's her exam for you. So I'm going to get you guys take the next 30 seconds again to turn to the person next to you. This is a patient who can't respond to you. She's protecting her airway. She kind of mumbles things at you. She can say words. She responds to your commands, but she has no idea where she is. She has no idea what's going on. She can't tell you your name, where she is, why she's there. So take 30 seconds, turn to the person next to you and talk about how you go about evaluating a patient like this. Oh, it's okay, as long as there's space. All I care about is if there's space. So if you want to stay down here, stay down here. I want I'm gonna call that 30 seconds for you guys. A lot of good chatter over here from this group. What did you guys talk about? How are you guys gonna evaluate this patient?
Yeah, so there were two things we were particularly interested in. First, what her effort of breathing is in order to sustain the level of oxygen she currently has. The other thing too is given that she has a saddle embolus, I want to see whether or not she's hypotensive, because that could be an indication for thrombolytics. And just generally, even when they're ANO times 0, you can see whether or not they're moving all 4 limbs, or whether there's a focal deficit, like there's one arm, but they're really not moving at all.
Yeah, so I agree. I think that's a really good way of saying it, right? So for the 8th floor, I was right next to him, so I hope you guys hear it, but I'll try and reiterate some of it. The first is, what is her work of breathing? She's got a PE. I'm most worried about her respiratory status. And then what are her vital signs? Because I'm worried about a massive PE and that she may need thrombolytics. But then there's also a lot of other things you can get from a patient who's ANO times 0, even if they can't follow all of your commands. So the point was, you can see if they move all 4 extremities. If they're flailing all 4 extremities around, that's a good sign that their 4 extremities are working the way they're supposed to be working. Not perfect, but better than nothing. Is there anything else anybody else would do to evaluate this patient? Figure out if they're different from before.
Like look in the notes to get her baseline.
Look in the notes to get her baseline. I think that's a really,
Someone.
ooh, that's even
Get
better.
baseline.
That's so, no, I think this is so valuable. You can spend 30 minutes looking in the chart to figure out what the old nursing notes and what the old H&P or progress notes said, or you can ask the nurse who's taking care of the patient. And we don't do this enough. I don't do this enough. And I completely agree with that. And so you're going to get those other pieces too, don't worry. But this is what the nurse tells you, because she's still on her shift. They change an hour after you guys. There's still some time. She's been taking care of the patient all day. And you say, is she different from her baseline? Is this new from her? Has she been like this all day? I see you non-squinting, so I'll help. You ask the nurse if this is different from her baseline. She tells you that the patient progressively worsened throughout the day. At the start of her shift, she was ANO times 3 inappropriate, a little confused, but knew what was going on. She knew that sometime after lunch, the patient became more and more confused and required more and more oxygen. So if that nurse has gotten to see that patient all day and you're just evaluating them, whether you're on cross-cover your own patients or seeing a new patient, they're incredibly valuable. Now I'll give you the other things you guys wanted to. Here's her exam. This is her exam from my evaluation note, so I can't promise you it's gonna be very good. I should say she does have increased work of breathing because she's distressed. So my question for you guys is, did this exam help? Which is what?
That she's confused.
Okay.
You know, and that we're seeing pretty much what we would expect to see with an embolus, these type of cardiac. I wouldn't say it didn't help, but it just like, you know, we didn't really pick out anything else that I would say would be that would. I would pursue it.
It confirmed things you already knew rather than giving you new information. Does that sum it up?
Yeah.
Dr. Hudler, is there anything else you would think about with a physical exam of this patient that we should think about? I should have put her JVD on there.
You know, I said, looking at JVD and then really listening for like a tricuspid murmur would be main ones. And then asking the nurse kind of like looking back what her blood pressure trend had been. And then making sure that she has good access as well.
Okay, so Dr. Hudler brought up 2
And
points.
then the other thing is like, are her extremities like warm? Are they well perfused?
And so that it seems like the other piece you're talking about is really about shock.
She clearly has like organ damage.
So I agree with both of those points. One is, what's her access? If you're worried that she's in shock, how do you determine if she's in shock? You feel her extremities, are they cold? We're thinking about cardiogenic shock. You can have cardiogenic shock from a PE or obstructive shock from a PE, right? So if your RV fails, your body still becomes cold. And then what are you going to do about it? What do you have to take care of her for?
Do you repeat that question? What was that?
So Annie made the point that really the question becomes, what are you doing about her shock? Is she in shock? She has signs of end-organ hyperperfusion, or she's confused, her brain is different. Or we think, right? She came in with a subacute encephalopathy, so it's kind of hard to figure that out. But is she in shock? And I'm trying to figure out, how am I figuring out if she's in shock? So I'm feeling her extremities. I'm trying to figure out if she's got JVD. If she's got a ton of JVD in extremities, I'm worried about her RV failure, and the tricuspid murmur being the same idea. So we've decided she has a PE. We decided she has a saddle embolus. We decided that she is sick. What other information do you guys want to know about this patient? Her blood pressure trend we'll get to. We're going to leave that alone for right now, and we'll come back to it. Let me tell you that over the past hour, her blood pressure has been that same, has not changed.
We were talking back here, thinking about getting a few other labs, so and probably imaging. So maybe get a BNP and a probe, and then probably you can also just toss a probe on her, or see if her squeezes. I mean, you know, Torments, ultrasound, but we definitely want to see if there's any sort of right heart strain that we can easily pick out.
She's full code. Good question.
Oh, and you can also look at her IBC. Yeah.
So why do you guys care about right heart strain?
Kind of tells you the embolus is hemodynamically significant in the sense that your right heart isn't able to perfuse through it. It's tiring out.
You're worried that the right heart is tiring out. Is it going to change what you're going to do for her?
It could.
How?
So I know that's one of the indications for TPA.
Tell me more about that.
So the PERT team here has a set of criteria that they use. And I think RV strain is one of them.
You're alone by yourself at night. There's no PERT team at Denver Health. There's you. You and the fellow. You're the PERT team.
The physical exam finding that can kind of tell you that is an elevated JVD. You can get an EKG and it's not specific, but sometimes you will see signs of right heart strain.
So I think you're absolutely right. I think what you're trying to do and what you're all saying is I'm trying to risk stratify this patient. What's the chances that they're going to die from the event they have going on right now? We're like, that's the goal. Why do I care about what their RV is doing? Is it going to tire out? Why do I care about if their RV is going to tire out? If the RV tires out, they're going to die, right? That's exactly it. And so we care about whether or not they have right heart strain. Why? Because it categorizes what type of PE they have and determines what their management's going to be. So we're going to take a second on this, okay? I'll give you your trope and BNP. Okay, so that's a positive troponin. That would be 0.285, I believe, on the new on our old scales. And that BNP is elevated as well. Normal's I think like 190 or something like that, less than 190. So her troponin or BNP are elevated. We've now decided that she has signs of right heart strain by that alone. So I'm going to ask you guys a question. You guys are going to turn to the person next to you. You're going to take whatever paper you have, and you guys are going to categorize how you think about PE in a patient. How do you risk stratify patients? And then we're going to come back together and do it as a group. So take the next minute to do that.
The only thing I want
Yeah, that's what I thought.
No, go away.
Got you guys. All right, called on you. Trying to get to this group over here. All right, let's come back together and let's talk about this. So we're trying to risk stratify this patient for the chances that her RV is going to fail. That's what we care about with the pulmonary embolism. So I have a group of R2s here with me that I know are just waiting for their opportunity to be a part of this. So I'm going to hand the iPad to them, actually. Let me give that to you. I'm going to give this to you. And I'm going to have you guys draw out for me under that tab that says pulmonary embolism, and I'll make it in the center of the screen for you.
Okay.
How do you guys risk stratify for pulmonary embolism? What did you guys talk about?
So we talked about like the massive versus submassive categorization to kind of risk stratify, because massive is going to change.
Yeah,
A marker.
yeah, that one. Yeah, you want that one. You use whatever color you want.
Massive is going to be somebody who's hemodynamically unstable, and you think that you need to give TPA to. And then submassive is kind of what we're getting at here with the right heart strain, that you're more concerned about having more hemodynamic problems from the PE, but that you don't necessarily need to jump on giving TPA to in the moment. And then you can have people who have less concerning that may have some hypoxia and tachycardia, but don't have right heart strain. I don't know what to call the third group.
But you're less worried about them.
Correct.
I'll let Danielle finish drawing that. I think that's a really good way of thinking about it. I'm gonna slightly change some of the terms we're using as we go through this, because I think things have changed over the past 10 years in how we refer to pulmonary embolism. Danielle, your handwriting is a lot better than mine, so I'll start by saying that. So what I'm gonna start by doing is, I agree with you guys, there's a third category over here. And I'm gonna call that low risk. Because what I really care about is their risk. I don't really care about how big their PE is. And that's why the terms we use have changed. Is really to get away from thinking about how big this patient's PE is, because her PE is big. Right? Her PE is big. It's in her saddle area. But is it massive in the terms that it's going to change what we do for her? That's the question we're trying to figure out. So I'm going to say low risk. I'm going to say, you guys are absolutely correct in how you define these two groups. I'm going to change the terminology for you guys. And I'm going to call it intermediate risk. And I'm going to call it high risk. Okay. And obviously the reason why we care is what's the chance that this patient dies from this event, but also what do I do for them, right? Those are the two things that we care about. What happens to the patients and what the heck am I supposed to do now? So I will further define intermediate risk into two groups for you based on the newest way we do this. And so there is a low intermediate risk. They were very creative. And there's a high intermediate risk. And suffice it to say, for our definition of the differences between those two, we know that both of those patients have right heart strain. We've defined that. The difference really is whether or not they have a simplified PESI score greater than 1. You can Google what that means on MD Calc. Or if they have more than one of signs of right heart strain being positive. So think about low intermediate risk as one sign of right heart strain positive, which is your trope, your BNP, and you can use an echo or a CT. Do not use an EKG. If you have one sign of right heart strain, you can see signs of right heart strain on EKG. They're just not the criteria used to determine this.
You said trope or BNP.
Trope or BNP or echo. To get to high intermediate risk, you have 2 or more signs of right heart strain. So trope and BNP, trope and echo, trope and BNP and echo. So our patient, if we're going to say that her blood pressure, so then the question, then we'll go over this high risk category for a second. You guys said hemodynamically unstable. Let's clarify that. What is hemodynamically unstable for a PE mean? They're massive, they're dying, they're hemodynamically unstable. What is that definition? Be more specific than that.
I'll say less than systolic, less than 90.
So that's one option. So requirement of vasopressors is another one. That does not meet the criteria necessarily.
Systolic drop greater than 40 from the baseline.
So one would be a systolic blood pressure drop. That's greater than 40. That's within 15 minutes and not responsive to fluids. After 15 minutes after fluids to finish that off. And then the third one is if they arrest. Makes sense. But we should think about it, right? Like we don't often think about that, but if they come in and they have a P and you think the P is why they arrested, they meet the high risk group. Right. So we've now defined our low risk group, meaning they don't have any signs of right heart failure, our intermediate risk group, meaning they have signs of right heart failure, and our high risk group, meaning they meet one of these 4 criteria. So we said she doesn't really meet one of these 4 criteria. I'll tell you, her SBP is at its normal range, has not dropped more than 40 in the past 15 minutes, and we haven't given her fluids because it's normal. She hasn't arrested and she's not on vasopressor, but she's got 2 or more, right? I just gave you a trope and BNP. You didn't even need an echo. And you can look on the CT scan. She's got signs of right heart strain on her CT. I didn't add that in. Exactly. So she meets the high intermediate risk category. So for the next 20 minutes, we're going to talk about why we care about that. Okay. And we'll talk about some more nuanced pieces to this. The question is, what is the difference in these patients, right? So if you want to look at some of the literature, the mortality rate at 7 days, about 1% here. It's about 6% here. It's about, this is approximately, about 7% here. It's about 15% here. This is in retrospective analysis. If you look at some of the studies, it's much higher than this in the high risk group. And that's why we care. That's why these patients stay in the hospital overnight, is this. So if you're ever wondering, like, why don't we just send these patients home? I can't tell you I have good data that says that them staying in the hospital reduces their mortality, but I can tell you that's why people get nervous about it.
That's 6 and 7.
6 and 7. So take this, sorry, you know, or Dave, I zoomed out. You want me to zoom back in for you?
Yeah, I mean, it's a blurry picture.
Maybe if you sat in the front row, it wouldn't be so blurry. All right. All right, so now we're going to talk about what we're going to do about these patients, okay? So I'm going to put this back up. And this is what we're going to think about. Is this group, what are we doing for these people? So let's start on the left side of the screen, the patient that's not this patient. And what do we do for people with low risk Ps? I love that. That's it. They get anticoagulation. And they can go home. Right? If they have no signs of RV strain, they can just go home. Anticoagulate them. Please use a DOAC unless they have a contraindication, really being their really bad renal function, or if they have antiphospholipid syndrome or something like that, where you're required to use warfarin. We're going to ignore that group for the rest of this because that's pretty straightforward medicine. This intermediate low risk group, what are we going to do with them?
Yeah, and then also start on the
I agree. So now you've recognized that these 2 categories are almost the same. Right? You can put this person directly on a DOAC. This isn't someone you need to heparin bridge, you need to put on Lovenox. This is someone who you can just put on a DOAC, watch them overnight, and then send them home in the morning. Or in 48 hours. It all depends on their risk, right? But we've defined what their risk is. We're going to skip intermediate high risk because that's going to be most of the rest of the discussion for today. As it always is about Ps, I'm going to try and give it a different approach for you guys than what we typically hear about. So let's talk about high risk. What are you guys going to do for this patient? Why do we give TPA? This is not, it's not really a read my mind question. This is the obvious answer. Because it removes the clot. My question for you guys is, does it work? Is there literature support us giving TPA for high risk Ps? quiet room.
My understanding is yes, but it's not great.
Here's that trial.
That's the one I was thinking about.
So this trial was done in, I forget, I think the late 90s. They had 4 patients in each group. They had 4 patients in the TPA group, which is streptokinase in this case. And they had 4 patients in heparin alone. Why do we do TPA? Because all 4 patients in the heparin alone group died. That's why we give TPA. So that's the basis of the literature for. You're right. There really hasn't been much. There has not been another randomized control trial that I could find. Dr. Hudler, maybe you could educate me on another
No,
one.
With the 100% mortality rate in heparin alone, it's going to be hard for an IRB to approve that.
Mhm, exactly.
So, that is why it's not been repeated.
It's hard to have equipoise when everybody dies. So that's why we give TPA. Davon,
Has there been thrombectomy versus TPA trial or something?
hold on. We're gonna get there. Oh, we're gonna get there.
Well, you did.
Yeah, no, that's a great question, right? Like, what if we take the clot out rather than breaking up the clot with lysis? So your answer for high-risk PEs, meaning their blood pressure drops, they arrested, they're on pressors because of their PE, or their SBP is less than 90, is you give them TPA. How do you guys give them TPA? How do you order that? How do you do that? Has anybody in here ever given TPA for a PE? How do you guys do it? Someone tell me. You ask the pharmacist. I agree. So you have to ask the pharmacist. They control this. They'll have a discussion with you. How much TPA do you give them and how long a period of time do you give it over? It's been a while.
I think it's over a minute is the first push. And then the next is over an hour. Is it like 100 milligrams total and you give like 10 or 20 will do it? Like as a push and you do the rest of like the 80, 90.
Yeah, so you guys are talking about whether or not you're giving a bolus or an infusion, right? So it all depends on the scenario. It's 100 milligrams is the total dose. We'll talk a little briefly about half dose TPA. The moral of the story is you don't need half dose TPA, don't use it. Just use the full dose, but it's 100 milligrams. If the person isn't coding, you can just give it as and they're higher risk for bleeding theoretically. Although there's no data to support that, that's anecdotal. You can give it over 2 hours as an infusion, as a continuous infusion. The other option is if you're in a code situation is you can push and then run a drip after if it works. But it's 100 milligrams. If someone's not coding, it's over 2 hours. Remembering, Dr. Hudler brought up the point of their access. Remembering that please place any access in the patient before you give the TPA. If they have one little IV in their hand, put the central line in before you give the TPA. Then they have to be monitored in the ICU for 24 hours. It's no different than strokes. So let's go to intermediate high risk groups. So we're going to talk about that. So for a massive PE, sorry, a high risk PE, I keep saying the wrong thing. If you're talking about a high risk PE, if you have time, you can do catheterized thrombolysis, but in most cases, these patients are unstable enough that you're just going to break the clot. Right? I think you're asking, the reason why this comes into play is really this intermediate high risk group. They're like, it's kind of on the edge. They don't look great. And you're like, man, we should figure out the way we're going to do this. And that's why we have the PERT team, is to determine the way we're going to do it. And because you have time to think about it. Remembering that nothing's an emergency. It takes time to mix TPA. You will not be pushing TPA the second you call for it, even in a code. So just remember that. So intermediate to high risk categories. These are the previously known submassive PEs. This is what we decided this patient has fallen into. So what do we do with this patient? You guys can take 30 seconds and turn to each other and talk about what you would do with this patient. Now is your choice. You know this patient's case. Now you get to determine what you would do with this patient.
Why do you think they'll do that? Why do you think we
All right, guys, let's come back together. That's 30 seconds. I'm gonna ask you guys, what do you want to do for this patient?
So we talked about anticoagulation that might have a quicker onset of action.
Tell me more.
So like Lovenox gets you quicker to therapeutic anticoagulation. So doing that over heparin or DOAC. And then piggybacking off of Davon, thinking about mechanical options in thrombectomy.
So would you do it? You have to decide.
Mm,
You can't tell me to think about it. You're gonna decide what you're gonna do.
yeah, I'm doing it.
Okay. So you guys are telling me no matter what, you're anticoagulating this patient. You had to choose Lovenox or heparin. Which one did you choose?
I would do Lovenox.
And then you guys said you would thrombolyse this patient. How would you do it?
Or thrombectomy. I would be calling IR and asking them all the questions.
Okay. I think that's a reasonable approach. Did any other groups have any other thought on the anticoagulation? Everybody want to give this patient
You can
Lovenox?
also do DOAC. I think technically this is still considered within the submassive category, right? So as far as anticoagulation.
You could do a DOAC, you're right.
And then I'm assuming we're gonna get to catheter directed thrombolysis.
How well can we reverse DOACs?
Not well.
Yeah. So the only reason why I would pause with a DOAC is if you decide you're going to lyse this patient and something happens, you want to reverse it, you can reverse Lovenox and you can reverse heparin. You can't really reverse a DOAC particularly quickly without spending lots and lots of money.
Yeah.
Precisely.
Yeah, I mean, that would be under the, that would be putting them on anticoagulation, knowing that you're not gonna go.
Exactly, right? And so that's why in this patient in particular, I would be careful doing that, right? There are patients with other clinical scenarios, like they're not on 10 liters of oxygen, they're still tachycardic, and they have a trope and a BNP that are both elevated, that you could say, yeah, they're probably okay with DOAC. This lady's got altered mentation. You think it's from her PE, or her hypoxia is getting worse. She's tachy to 140 and she's 72 years old, right? And that's why clinical scenario matters, because you're absolutely right? There are things you have to think about why the patient you're looking at is more important than the trial you're in. So I agree, right? Lovenox acts almost immediately to be therapeutically anticoagulation. Heparin can take hours if you don't use a bolus. So I'll tell you what I did. So I gave this patient Lovenox, and then I gave them heparin. We'll talk about why. That was an accident. It was not. It's not that it wasn't purposeful. It's that the decisions changed minute by minute. So the question I have for everybody in here is: if I give them anticoagulation, can I still thrombolyse them or do thrombectomy? Yeah. The answer is yes. In Europe, they leave people on anticoagulation while they do thrombolysis. So do not worry. Your first step should always be to anticoagulate these patients, unless they're a high-risk group. Because you can either shut the heparin off, or in Europe, they just lyse them. You don't worry about it. Okay? So do not worry about your anticoagulation. I agree with those two choices. I think if you decide you want to do heparin because you think it's easier to shut on and off, sure, but I agree Lovenox acts faster. So now we're going to talk about thrombolysis and thrombectomy. And so I had one, I'm going to put my yeses up here. I'll put my no's over here. It's almost like the devil was yes and the heaven was no, right? The angels. So I have one group say yes. How many other groups say yes, they would lyse this patient? You can raise your hand, or we can close our eyes and raise our hands. You guys tell me. So I have one group. So how many groups said no, they would not? One. How many groups didn't choose? We're gonna have to work on that, guys. You're alone at night by yourself. You have to make a decision. So 50-50 split is what we're gonna call it, for one that would do thrombectomy and then one that wouldn't, thrombolysis or thrombectomy. So Davong and Guille and Yunnan asked about an echo. And I'll be honest, this is done by yours truly, so you can make fun of it all you want. You guys want that again? So does anybody see anything abnormal? What do you guys see? Yeah, what is it bouncing around in? What cavity is that?
Can you play again?
That's correct. So this is the RV. RA. LV. So there's something big and white moving around the right atrium, right? You can see your valves here. You're here and here. And so I'll have you guys think about whether or not it's going to change your decision, but we'll talk about that in a second. You did this because you thought it would be a good academic exercise, and here you are. You're like,
I am. I'm academically debating it.
and so now you have to make a clinical decision based on your bedside ultrasound. But we'll get to that. So let's first talk about what this patient, if they didn't have this thing in their RV, we should do. So there's a bunch of trials looking at thrombolysis in patients with this high risk, intermediate high risk group. Has anybody ever heard of any of them? What any of them mean? That's why we're here, is to learn. So that's okay. So this is the pytho trial. This is comparing systemic thrombolysis to heparin alone. And they had this incredible outcome where people became hemodynamically unstable and died less hemodynamic instability and less death, composite endpoint. If I broke those two up, really, they just didn't become hemodynamically unstable. That's a good thing though, right? No one seemed to have answered my rhetorical question. So the question is, what's your risk for giving someone thrombolysis, right? You're worried someone's going to bleed into their brain. And obviously the group that got thrombolysis at higher risk of bleeding. And all you did was make them less hemodynamically unstable. You did not affect their mortality. Composite endpoint, because they put them together, they could say that. So this is why everybody's like, oh, this is why we don't do thrombolysis in intermediate high risk groups. Then Dave Long said, but what about like catheter-directed lysis? What if I just give a little bit of TPA next to the clot? Can I get away with that? Whole bunch of trials. Really two. So the first one is Ultima. That's that top one. That's where they actually randomize people to ultrasound-assisted catheter-directed thrombolysis versus anticoagulation. And then Seattle is the bottom one, where it was really just a prospective review of cases of patients who got catheter-directed thrombolysis. And both of these trials found the exact same thing, which is they decreased RV size and stream. Seattle compared it to baseline, and Ultima compared it to the heparin alone group. To me, that doesn't really seem like a patient-centered outcome. I don't know about you guys. But we got new fancy toys that you can do it for. And we know that it's relatively safe. People bleed into their brains, but not everybody. And so the question becomes, who is this good for, right? Like, it doesn't mean don't ever do this. It means you have to figure out who is the right person to get this. And so that's why we have a PERT team, and that's why we have all these other pieces that we take into account. Dave?
So I still have the question after these trials, because they didn't compare catheter-directed thrombolysis to systemic. And I don't know of any trials that did that.
Correct. There's no trial that does that. We're going to talk about some retrospective review of differences in method. So that's a good question. You're right, though. There is no trial that compares catheter-directed thrombolysis to systemic. The answer why is because, well, I'll show you why they probably won't ever do it. So that's essentially how we got to where we are with the fact that higher intermediate risk typically does not get TPA, is because the trials don't really give us great outcomes for most patients. But we have a patient with a big clot. I'll show you this guys again because it's fun. You guys see that white thing moving around in there? Maybe people are imagining it. I imagined it at first. I had to call cards and they were like, yep, that's there and that's a thing. You should do something about that. So it's this guy flopping around right here. And when I play it, obviously my thing won't stay there. It's that little white thing moving around inside that cavity. So what do we do with clots in transit? That's what this is, right? This is a clot in the RA. She's got a big PE. What do you do about this? So I brought this up. This is a question I brought to this group because I've seen this twice now, and that's recency bias, but I've seen this twice now in the past 6 months because of COVID. COVID's not about to go away. I think we've all learned that over the past 24 hours. And so the question is, what do you do with patients like this? Because you're going to see them at some point, I imagine. Does this person get lysed even though she's high intermediate risk? Who in here has had a clot in transit before? What was your experience with that? What did people do?
Well, he was intermediate risk because he was like doing this, so he got TPA. But we talked about like angiovac and like just going in and trying to suck out the clots. Except it was in his RV, so then they're like, it would destroy his capacity valve. So that doesn't work.
Peter, do you have the same patient or a different patient?
I think it must have been a different patient. This was another COVID patient.
Mine was also COVID.
Oh, yeah, we actually did post it.
And what did you guys do with that clot?
So this patient went to the NICU for TPA, but ended up not actually getting TPA. This guy had that. I think they were a little bit more stable.
Was this the patient that came over from Denver Health? Did either of you have the patient that came over from Denver Health?
This was at Denver Health.
This was at Denver Health. So Denver Health, fun fact, doesn't have angiovac or thrombectomy
So they were only TPA.
or catheter directed lysis. Anybody else have anything else that they ever seen may do with a clot in transit? So I've seen surgical thrombectomy. And systemic lysis. And then the last one would be catheter directed thrombolysis. So there's all of these options. And the question is, which one's the right one? This patient can't possibly be like the other patients with a high intermediate risk PE. Right? Maybe? What's the answer to that question? I didn't know. And so that's why I did this, because I don't know. I did partially what they told me overnight, but partially I was like, this lady's getting sicker. We should do something rather than just give her anticoagulation. So I looked it up. And so this is the PERT consortium guideline. Nope, that's not it. Here's your prognostic significance. This is why we care. This is, does it matter? Are these patients different? Prognostic significance of right heart thrombi in patients with acute symptomatic PE, a review. Associated with, and I'll underline it for everybody, short-term all-cause mortality in all patients with an odds ratio of 3.0. And with PE-related death of 4.8. These patients die more often. There's some question as whether or not they die more often because they're more likely to be hemodynamically unstable, or is it the clot itself that makes them more likely to die? There's no good answer to that right now. It does seem like hemodynamic instability is an independent risk factor in these patients for death. But the question becomes, is if that clot in her RA goes to her saddle, that's already obstructing bilaterally her PAs, will she die? And do you want to take that risk? Well, I already can tell you that she's more likely to die than if she didn't have that clot. So what's next? What do we do? I still don't know what the answer is. I left one of my studies behind, guys. That's a bummer. So let me tell you that there's some interesting literature out there before we go. There's some interesting literature the way cardiology asks that you do this, and that CHEST or the PERT consortium asks that you do this. So the JACC guidelines actually suggest that surgical thrombectomy with sternotomy has better outcomes. Their data is a little bit older, but that's where all the cardiology of like, we should cut that out comes from, because they actually have, and we'll talk about some of their data, but they have some data that you should cut it out. But then Dave said, well, what if I compare them all side by side? What do I do that? And so that's this literature. So this is specifically in right heart thrombi. This is not just in high intermediate risk PE. Okay. But this compares 3 modalities: surgical embolectomy, thrombolysis, and anticoagulation alone. The left side is it's the mortality at 30 days. Sorry, it's the inverse of the mortality at 30 days. It's survival at 30 days. And so what you can see here is actually patients who get thrombolysis, systemic thrombolysis, have better outcomes than patients who got thrombectomy. There's no literature that says that we should angiovac it, or we should do catheter-directed thrombolysis first, these things. But patients were actually more likely to have better outcomes if you just did thrombolysis than if you sent them to an OR or somewhere else. That's something happened. And if you just anticoagulate them, that's a pretty significant risk. This is hemodynamically stable patients, right? That's our patient to some degree. And so this is the literature that's out there on these patients. And so then the question becomes, what do you do with this literature, right? Did someone put it together? And so the PERT consortium is the same group that had one of these other articles that I put on here that I forgot to download, I think, for you guys. But the PERT consortium created guidelines that essentially said if a patient is high intermediate risk and has other signs that they are failing, which really means increasing oxygen requirement or other signs of end organ damage, then there's someone you should strongly consider thrombolysis, thrombectomy, clot removal in. Based on this data, based on the fact that they die more often and that patients survive more often when you do thrombolysis or thrombectomy. So know what happened with our patient. Because after we saw her RA clot, we called IR. We said, hey, do you want to take this clot out? They said, well, why don't you call us in the morning? We'll see how it looks. And we said, well, she's on 10 liters of oxygen. She's not awake and her heart rate's 140. We'd rather not wait. And they said, well, we are not going to come in tonight. And so we did systemic thrombolysis. This is anecdotal evidence at this point. So just so we know, this is a data-free zone after this. Her heart rate went from 140 to 110. She was on 3 liters of oxygen by the time I left in the morning. And she had an echo. Well, I didn't do one before, so they didn't have anything to compare it to, unfortunately. So she had, I think the biggest note here, which made me feel better about this decision when we think about these patients, is she had moderate to severe RV dilation with moderate to severe systolic dysfunction. So she had severe RV, or she had RV failure in this setting. And they didn't see clot when they looked at it, hopefully because we lysed it. I have a follow-up CT, her clot looks better. But again, that's not a marker we care about. Who cares if her clot looks better? We care if she survives. So she did survive to discharge. She unfortunately passed away about a month later due to an unrelated cause, likely due to her underlying dementia. Dr. Hudler, do you have anything to add to that?
No, I think one of the other things we don't talk about is just it is such a gray area, and that's why the PERT team exists. And so we're always happy to take calls, but it is one of those things where you also think about like, would one other clot kind of take this person over the edge? And so that would kind of push you more towards like thrombolytics in someone with an intermediate high risk. So thinking about, if you're trying to risk stratify, you have time, you can always, get an echo for one if they have RV dilation and just like systolic dysfunction. You think one more tiny little PE could really tip them over the edge and do a PE arrest. And so that's one reason we do always ask that you guys get echoes in these patients. So it helps us with treatment. And then honestly, you'll see people get like angiovacs and a bunch of catheter directed lysis, and we just don't have data for that, but they're fancy toys. They work really well for patients. And so that's a great zone that we're always happy to help out with and go from there.
So that's everything I have for you guys for today. So just a reminder what we talked about. First, we recognize that this patient who's borderline unstable, requiring ICU transfer, that you can take the time to look at their chart before you run off to see them, because you should gather more information to know what you're getting yourself into. And that even though they're altered and confused, you can still get relevant physical exam information from them. We then talked about how we now stratify pulmonary embolism, remembering that we've moved away from submassive and massive because we don't care about the size of the clot. We care about their risk of dying from their clot. And so we split it up into 4 categories based on that. We then moved over to talk about how we manage those patients, knowing that low-risk patients get anticoagulation and go home. Intermediate low-risk patients get anticoagulation and go home the next day. High-risk patients get TPA because they die more often. And that high intermediate risk patients get a long discussion about what you do with them. The question then came up with clot in transit, which we've seen more and more with COVID, as we have 3-4 people in here who've experienced this now, and you'll continue to see it, that there's not a lot of great data out there what we do with these patients because they're so rare, but there is significant data that suggests these patients die more frequently, maybe from their clot, maybe because they're more likely to be hemodynamically unstable, and that's why they have a clot in their RA or RV. But there is data that suggests that thrombolysis is superior than anticoagulation alone in these patients. What question do you guys have for me? All right, that's it for today. Tomorrow, Manny's doing conference. Woo! Not just me. Okay. Manny's doing conference. I'm excited.